So good day to all. Good morning, good afternoon, good evening to all the attendants attending globally. My name is Alberto Pereira. I'm a professor of medicine at Amsterdam University in the Netherlands, and I chair the ESE Rare Disease Committee and the European Reference Network for Rare Endocrine Conditions. And I very much like to welcome you also on behalf of my co-chair, Hanna Nowotny. Hanna, could you briefly introduce yourself, please?
Of course. Hello, everyone. It's a great pleasure to be here today. My name is Hanna Nowotny from the University Hospital in Munich in Germany, where I'm part of Nicole Reich's working group on CAH. And I'm very much looking forward to this meeting and to co-chair the session with you, Alberto, and also looking forward to the excellent selection of speakers.
Yes, well, thank you very much. So as you can see, we're going to talk about CAH, the diagnostic and therapeutic challenges across the entire lifespan, a joint webinar with ESE, ENDO-ERN, and ESPE. And I can tell you that this is a unique educational opportunity. So having said it, first of all, I would like to thank ESE, ENDO-ERN, and ESPE for organizing this informative session. I also would like to thank Ricordati Rare Diseases for their sponsorship of this webinar and the ESE Educational Calendar 2025. In addition, I also would like to thank Crinetics Pharmaceuticals and Neuroendocrine for their sponsorship on this webinar. And you should know that this session will last approximately 1.5 hours, including the presentations and the time for audience questions. Please, if you have questions, ask these throughout the Q&A button at the bottom of your Zoom screen. And if you have any technical or administrative questions, please message the ESE team using the chat box on your Zoom toolbar. We have to notify you that this session is being recorded and will be available on the ESE website as soon as possible after the session has been concluded. So as you can see here, we have a very exciting program of 3 eminent and very good speakers and experts in the field. We will start with Hedi Claahsen van der Grinten, followed by Henrik Volhammer and Ricardo Poffi, which will all be introduced appropriately in a second. So having said that, I would like to continue with introducing the first speaker, and that is Professor Hedi Claahsen van der Grinten. Oh yes, so the office accordingly reminds me to please scan this QR code because we need to have a good evaluation of this educational webinar. So having said that, may I introduce Professor Hedi Claahsen van der Grinten. She is a pediatric endocrinologist at Radboud University Medical Center in the Netherlands, and she is a full professor at Radboud University Nijmegen since 2021. Professor Claahsen van der Grinten has many hats. At institutional and national level, she chairs the National Congenital Adrenal Hyperplasia Working Group, and she's a founding member of the steering committee of the Radboud Adrenal Center, which is a national international expertise center for diagnosis and treatment of adrenal diseases, both in children and in adults. Furthermore, she is the chair of the Metametic Disease Group of sex development and maturation of the European Reference Network of Rare Endocrine Condition, and her research focuses on different aspects of CAH and also DSD, with an emphasis on the etiology of testicular adrenal rest tumors in DSD. And presently, she even extends her research activities with a focus on transgender care in children and adolescents. Hedi, it's a big pleasure for me to be able to introduce you, and we're very much looking forward to your presentation. Professor Claahsen.
Thank you, Alberto, for this kind introduction. I will try to share my screen. Is it visible for everyone?
Yes, it is.
Oh, thank you. So, yeah, first of all, I would like to thank the organizing committee to talk about one of my favorite topics, that is CAH, and especially the topic of today is diagnostic and management challenges in CAH with a focus on adolescence and transition. And I will approach this question by using two illustrative, I hope illustrative case discussions, which I hope will make this session more practical. These are my disclosure. And I would like to start with a brief overview of CAH, which is relevant for this lecture. I think you all know that the adrenal cortex produces three classes of steroids, that are the cortisol, aldosterone, and the adrenal androgens. And especially cortisol is stimulated by the stimulation of ACTH, which stimulates the adrenal cortex, and on the background, the cortisol will inhibit ACTH stimulation, so a very nice negative feedback. In CAH caused by 21-hydroxylase deficiency, and now we focus today on 21-hydroxylase deficiency, both cortisol and frequently also aldosterone synthesis is impaired. And due to the lack of the cortisol production, there is a lack of a negative feedback on ACTH with a persistently stimulation of the adrenal cortex. And that makes this chronic stimulation of the adrenal gland leads to an increase of androgen production that is not affected. So the chronic stimulation results in elevated adrenal androgens. And you can see it in this figure with here the block of 21-hydroxylase with a lack of aldosterone or cortisol, but an increase of adrenal androgens. And that makes that CAH also has different clinical profile with the typical features of adrenal insufficiency, so cortisol deficiency, with the typical features of hypoglycemia, hypotension, weight loss, and dehydration in the most severe form, and hyperaldosteronism, hyponatremia, hyperkalemia, hypertension, and weight loss. But on the other hand, also symptoms due to the extreme high levels of adrenal androgens, which leads to virilization already prenatally, but in later life also other symptoms just such as precocious puberty, acne, hirsutism, menstruation and disturbances, and so on. In diagnosis and follow-up, we usually measure the biomarkers, which are typically 70-OHP and androstenedione in 21-hydroxylase deficiency. So these are these markers. ACTH, which is elevated. We measure renin levels to measure the RAS system, and of course sodium and potassium. And nowadays we more and more also measure 21-deoxycortisol and also 11 oxygenated androgens, which are gaining diagnosis relevance, I think, in the next years. And of course, genetic confirmation is also, I think, standard by mutation analysis. So this is our diagnostics. The general treatment goals are figured out in this slide. So the treatment objectives in CAH differ from those in other adrenal insufficiency conditions. So in addition to the preventing of adrenal crisis that we all know, so we give the substitution of cortisol and mineralocorticoid replacement, we also aim to suppress ACTH and thereby also lowering androgen production. So there are two goals in the treatment. The first goal is substitution of cortisol and aldosterone and the suppression of ACTH. And this last aim often requires supraphysiological dosages of glucocorticoids, which of course poses long-term risks. There are some specific treatment goals during adolescence, so adolescence where we focus on in this talk. And these specific treatment goals are achieving normal growth and final height, maintaining a healthy weight, ensuring normal pubertal and also psychosexual development, of course, prevention of Addisonian crisis, but also prevention of long-term complications and one of them is the prevention of gonadal dysfunction, when you come to that in one of the next talks. The current cortisol treatment that we all know and that is especially established for patients with all forms of adrenal insufficiency has important limitations for CAH patients, as the current strategy fails to effectively suppress ACTH to the HPA axis that is necessary to suppress ACTH. So hydrocortisone gives result in very high glucocorticoid levels after each dose, that potentially followed by a period of low levels of glucocorticoids after 4 or 6 hours. You see that in this figure, leading to periods of inefficient suppression of the HPA axis and the need of higher glucocorticoid dosages. So there are periods within 24 hours of over and under treatment during the day. And as pediatric endocrinologists, but also as adult endocrinologists, we all know this delicate equilibrium between undertreatment with subsequently elevated androgens, leading to these typical symptoms that we all know: early puberty, acne, hirsutism, but also gonadal dysfunction and increased cardiovascular risk, but also the overtreatment, on the other hand, that leads to obesity, hypertension, decreased final height, and increased cardiovascular risk. There are some challenging students. One of them is the alteration in cortisol clearance in adolescence, so an increased synthesis of cortisol into cortisone, and that is due to an increased glomerular filtration rate, and that is nicely illustrated in one of the papers of the group of Kamandari already several years ago, mostly explained by an increase of growth hormone in IGF-1. And as you can see in this figure, you see here that the clearance in the pubertal state is much higher than in the prepubertal state. And we have to take this into account during our treatment. And other challenges, especially in boys, is that despite that there are less effects from androgens in boys, because girls will develop undesired symptoms of hirsutism, acne, and menstrual disturbances, but males adolescents seem not to have serious problems when not regularly taking their medication. So compliance is an important thing, especially during adolescence. And there are some other treatment goals and some other challenging points during adolescence. And I want to highlight in my lecture especially 2 points that are weight, compliance, and gonadal function. And I will focus on the female problems, as the male aspects will be discussed in the next slide. So we will start with after this introduction with the first case. This is a 15-year-old girl with a classic CAH due to 21-hydroxylase deficiency. She was treated with hydrocortisone and fludrocortisone since the neonatal period. She was treated with 12 milligrams per square meter per day hydrocortisone, which is a moderate dosage for a CAH, and 150 microgram fludrocortisone with good adherence, a normal start of puberty with a 10 of 4, normal weight, normal growth velocity, but no menarche yet at the age of 15 years. So the question that we have, is menarche generally delayed in CAH, or is this abnormal, and should we perform additional tests? Some background information about that. The literature indicates, and several studies indicate, that the average age of menarche in girls with CAH is not significantly different from that in non-CAH females. And regular menses is a good marker for good hormone control, as poor hormonal control due to elevated androgen will interrupt the menstrual cycle and leading to menstrual irregularity. So we checked the hormones in this patient, and what we found was pubertal levels of LH and FSH, moderate level of estradiol, and we usually measure 70 OHP and androstenedione in saliva in our center. And you see here the reference values. You can see that 70 OHP is increased with a level of 4 nanomol per milliliter, and also androstenedione is increased. So these findings suggest poor hormonal control, particularly elevated adrenal androgens. So what are the consequences of elevated androgens in general? We know that elevated androgens will lead to an impaired negative feedback on the GnRH. So there is an increased GnRH pulsatility, which leads to increase of LH production, and relatively low normal FSH disrupts the normal follicular maturation, leading to anovulation and menstrual irrigation, which explains the menstrual disturbances. LH, so the elevated levels of LH also stimulate the TICA cells in the ovaries to produce androgens, which also contributes to the elevated androgens. While we use to measure the classic adrenal androgens such as DHEA and androstenedione more recently, the potential contribution of 11 oxyandrogens, and you saw that in this figure during the introduction, are more and more measured and have a big contribution also on the adrenal androgen source. So in this figure from the group of Auer, you see elevated 11 ketotestosterone, 11 oxyandrogens in patients, which are increased in patients with amenorrhea compared to CAH patients. So in this case, we increased the hydrocortisone to 14 milligrams per square meter per day. Hormonal control improved as androgens normalized, and you see that in this table. So androstenedione normalized, and 70 OHP is still slightly elevated, which we usually want to have. So we usually try to balance the androstenedione within the normal range with slightly elevated 70 OHP to avoid overtreatment. But after 6 months, there is still an absence of menarche. So the question again is, why does menarche still not occur, and should we wait for additional 6 months? So again, a little bit background. We know that the menstrual cycle in CAH patients can be disturbed also by elevated progesterone, so progestins, also 70 progesterone of adrenal origin, also in the absence of androgen. And we know this effect very well from our treatment with the progestins, so with orgometril or other preparations to suppress menstruation, because this progesterone causes also the inhibition of follicular growth, endometrial proliferation, and failure of endometrial breakdown. And this is nicely illustrated in this case report published many years ago. This is a case report of a girl 15 years old with a similar background that of our patient with amenorrhea, primary amenorrhea at the age of 15 years old, with apparently good hormonal control. And you can see this in this figure where the girl collected saliva every day. You see here a normal androstenedione level, but slightly elevated 70 OHP, and stepwise the glucocorticoids were increased with a lowering of the 70 OHP values, still elevated progesterone, and at some level here, when there's after 4 steps of increasing glucocorticoids, there was first menstruation, and after this first menstruation, with also the suppressed androstenedione and lower 70 OHP, and you see a more cyclic pattern of progesterone. But again, the challenging equilibrium of over and under treatment has to be looked at. And this may be improved by recent development in managing CAH, which I would like to manage. That is the development of modified release hydrocortisone formulations, and these are designed specifically to address one of these major challenges in treatment. So the early morning surge of the ACTH, which is very difficult to address, and which drive this androgen excess. And unlike conventional hydrocortisone, these delayed and sustained release tablets aim to replicate the more natural circadian rhythm of cortisol secretion. This formula consists of an inert core with hydrocortisone covered by a pH-sensitive delayed release coat, leading to a delayed release. And this also allows twice daily kind of toothbrush regimen with a 2/3 dosage in the evening around 10 o'clock and 1/3 in the morning. And this medication is now registered, and I think in many countries, for children 12 years and onwards. There's still no data available in children above 12 years, but registered for at least 12 years and older. So what we did in this case, we started with a modified release hydrocortisone twice a day with a similar day dosage as previously used with a conventional hydrocortisone. And with this treatment strategy, the 70 OHP in the morning decreased and menarche occurred after 4 months. But of course, we carefully monitor treatment of overtreatment by measuring blood pressure and weight. So we move forward to the second case, a 14-year-old girl with salt wasting CAH, and also this patient was diagnosed at birth due to ambiguous genitalia. She was treated with hydrocortisone, fludrocortisone since the neonatal period. No severe events, no illness, normal development. And she started with breast development at the age of 11 years, and menarche occurred at the age of 13. But she developed also irregular menstruation with a current medication of 13 milligrams per square meter per day in 3 dosages, and fludrocortisone a quite high dosage of 250 micrograms per day. And there were doubts about adherence. This is her growth chart, and this growth chart shows a nice pubertal growth with early bone age advancement, but finally she reached final height, I think, within her target range, which is fine. But on the right side, you see an increase in weight since early childhood, so severe obesity. And here you see the results of the 70 OHP and androstenedione levels in the morning saliva, and you see a huge rise in both precursors over time. So this suggests poor biochemical control. So we have this patient with irregular menstruation, with poor hormonal control, and with obesity. And therefore we are faced with a typical dilemma that we, I think, all know. Should we increase the glucocorticoid dosing to better control androgens, or should we decrease to reduce metabolic risk? So it's known that children and young adults with CAH are at risk to develop obesity and insulin resistance, and also metabolic syndrome, and the whole spectrum of metabolic syndrome. And there is evidence that children with CAH have increased visceral adiposity, which has been linked to the metabolic syndrome and cardiovascular disease. And the causes are multifactorial. Of course, glucocorticoids play an important role, but also the elevated androgen themselves and the unphysiological hormone replacement. And more recently, a paper published by the group of Bacilla in the European Journal from this year showed a clear relation between the hydrocortisone dose and leptin concentration, and a relation between elevated androgens and adiponectins. But on the other side, obesity itself complicates CAH control, influencing cortisol metabolism, so cortisol clearing with altered glucocorticoid sensitivity, but also an interference with the HPA axis and an increase in androgen production by speculated insulin excess that can directly stimulate adrenal steroid synthesis and elevated leptin stimulated androgen production. And here you see a study of the group of Ryanair, and they showed that weight loss in CAH patients was associated with a significant decrease in androgen levels, highlighting the impact of obesity on disease control. So in this patient, we, as a first step, we worked on lifestyle support and improving adherence, and of course, education and patient engagement. So in my experience, poor hormonal control in adolescence hormonal control is a key in the treatment and the follow-up of adolescents. Poor hormonal control is mainly caused by the lack of compliance, and therefore one of the most critical factors in managing adolescents with CAH is education. Starting early, educating not only parents but also patients themselves, starting at a very early age, is crucial to ensuring treatment, adherence, and successful transition to adult care. And to support this, we have developed several educational modules and tools, which you can see here, including animation and e-learning platforms. And these are available through our website, Adrenal EU, and can be easily accessed also with this QR code. So when you're interested, look at this slide as well. I will give you a couple of seconds to check this QR code. So what are the success measures in adolescent care and transition? Of course, medical stability, controlled androgen levels and a female's regular cycles, psychological adjustment, confidence with self-management, absence of anxiety, depression, educational outcomes, understanding the condition and its long-term implications, and absence of long-term metabolic and reproductive problems, and of course, satisfaction with care and with the transition care. And that brings me to my last slide. Key learning points I would like to summarize. Optimal hormonal control and good compliance is a key for in adolescents with CAH. Evaluate hormonal control by regular measurements of adrenal steroid precursor throughout the day, monitoring of weight, and if necessary, lifestyle interventions. Consider alternative modified release glucocorticoids to optimize treatment, and of course, regular education and training. And for females, assess regularity of menstrual cycling during every visit, and when irregular menses is present, measure androstenedione, but also measure 70-OHP, progesterone, and progesterone. So this is the end of my lecture. I'm happy to answer your questions. I will stop sharing, I think.
Yes. Professor Claahsen, thank you very much for this beautiful presentation with very illustrative cases. So we have time for some questions. There are two questions in the chat box. The first refers to case 1. So what frequency of treatment intraday? What times during the day? I think it refers to the hydrocortisone treatment, but I'm not sure.
Yeah, normally we dose hydrocortisone, the conventional dose, 3 times a day, in the morning at 7 o'clock, around 2 o'clock, and we try to give the last treatment in the night, around 10 o'clock, 11 o'clock, so before bedtime. There are some discussions, of course, about the highest doses in the morning or the evening. Probably this is the question, I'm not sure. Yeah, there are a lot of discussions about the highest doses in the morning or in the evening. I prefer, in some patients at least, highest doses in the evening to suppress this ACTH surge. But with FMODI, I think with the delayed release medication, it will become more and more easy. So hopefully that we do not need this discussion anymore with this medication. And there's another question I see, education early age, at what age? Yeah, we start with our transition program already at the age of 12 or even earlier. We try to involve the patient in the whole spectrum, but we start with a transition program at the age of 12.
I think there's another question on modifications of the treatment during pregnancy. What would you advise on that?
Now, I'm a pediatric endocrinologist, so I prefer that, Hannah, that you can answer this much better than I myself.
Well, we actually normally say that we try not to change anything during pregnancy, and try to have all the patients in optimal control beforehand, if that works. But yeah.
Yeah. I read another, oh yeah, probably you could read it, but I read
Yes,
another.
we still have time. So in overweight adolescents with poor hormonal control and primary amenorrhea, which should be tested first? Weight management or increasing the dose? What should be prioritized? I think it is meant.
This is a very good question and very challenging question as well. Of course, you have to balance both, and it is, and as you know, it is more easy to increase the dosage than to convince patient to work on lifestyle. But in my opinion, even increasing dosages without working on lifestyle does not really have any effect on hormonal control. So we try to do both, to balance the glucocorticoid dosage, but to prevent dosages above 17 milligram per square meter, which is a very high dosage, and to convince the patient that, yeah, lifestyle is an important thing.
Okay, and I think that it's a very elegantly bridges to the last question. Could you briefly answer whether there's any room in addition to lifestyle and diet changes for GLP-1 agonists in these patients?
Yeah, good question. I think we do not yet have an answer on that. I have no patients on GLP-1 agonists actually, but I can imagine that when there are more and more problems, and you can exclude that obesity is due to high levels of glucocorticoid, that there could be some space. But actually, I haven't treated the patient with the GLP-1 agonists, and I think we first have to look on really the causes of obesity and to exclude overtreatment.
Okay, thank you very much. So there are many more questions in the box, so we will answer them, but not now during the live webinar. Thank you very much, Professor Claahsen, again for the very elegant and excellent presentation. And I propose that my co-chair, Dr. Novotny, now continues and introduces the next speaker.